of the conference.
We hope you had We hope you had an engaging CME yesterday, and we look forward to an exciting lineup of talks, discussions, and exchange of ideas today.
We now begin with session 1 of the scientific program, focused on the theme pharmacology and airway.
This session brings together exciting perspectives on sedation strategies, anticoagulation dilemmas, airway management, and the use of ultrasound to enhance airway safety.
To chair this session, we are pleased to welcome Dr. Ravindra US, HOD, Srinivas Institute of Medical Sciences, Professor Srinivas Institute of Medical Sciences, and former HOD, KS Hegde Medical Academy, Dr. Ramkumar Venkateshwaran, former HOD, KMC Manipal, and trustee, Mission Smile, and Dr. Sudhir Hegde, former HOD, Father Muller's Medical College.
We now hand over the session to the chairpersons.
Our first speaker this morning is Dr. Subramaniam Mahankali, currently serving as the Regional Director of Anaesthesiology Services at KIMS Hospitals, Mangaluru. We request you to kindly proceed to the stage, sir.
So, good morning to everybody. While the speaker is getting ready, the topic for the first lecture is Remimazolam and remifentanil, new sedation superstars. I was fortunate to have worked with Subramaniam for a very short time. And without wasting any more time, I think we'll go on to the topic.
Sir, you're one of those who helped me at the times when I had to make decisions. And it's important to have a friend or a buddy or a mentor who can guide you at the right times. Ramkumar sir was there to help me make a decision that I should go to UK, go train there and come back, and it's exactly what I did, sir. Thank you very much for your guidance, sir. Today, I'm very excited about talking about these two things. I've had a personal experience with one of them, and I can't wait to get my hands on the other one. So, now, I went to UK from here in 2002. The first week itself, I met a guy who was using TCI Tiva for nearly 2 years and said he has not touched a volatile. He's not been using morphine for such a long time. So that got me into thinking, what is this drug? What is this technique? And that is when I got introduced to remifentanil. Now, remifentanil, in India, it is available for all of us to use. Unfortunately, the various government regulations are still not put in my hand, but I will be soon having. But I will share my 10 years experience, how to dilute and how to use it. It's available in 2 formulations, 1 milligram and 2 milligram formulations. The key thing is it is available as a powder. Now, it is usable only as an IV injection, not for any other routes. You should not be using it for either intramuscular or intrathecal. But what we should remember is probably it's 100 to 200 times more potent than morphine. Now, indications, anywhere you need a fantastic pain relief, that is where you want to use it, both as an induction and as a maintenance agent. People also use it for postoperative pain relief, labor analgesia, and also in monitored anesthesia care, or perhaps sometimes in sedation for procedures like awake fiber optic intubation. Now, why is it more exciting? Why we want to have a look at this? Why we want to have a hand on this is because it has got a very quick onset. We like anything which comes on quickly and which goes on very quickly. That is the art of anesthesia. Now, it is safe to use in anybody with an organ disturbance, for example, renal or hepatic disturbance. And if you are using it for pain relief, it reduces your dose of other things, for example, hypnotic as well as muscle relaxant. The 3 decades of experience shows that the side effects are very minimal. Now, why? What is special about it? It's a pure mu receptor agonist. Now, the binding with other receptors is very little. As a result, you will not have much side effects. And it's safe to use in other renal impairment as well. Now, what is special about this is, this is a very important part because a lot of pharmacological advances is happening based on what is here. So this drug is not dependent on either the liver or the kidney to make it an inactive metabolite. So it is metabolized by plasma and tissue esterases. That is the key thing here. Now, this group of drugs where it is metabolized by plasma and tissue esterases is what will be the future. I can say in 10 years from now, we probably will have 10 more drugs in this group. Now, let us compare it to what we generally have a use. I mean, for fentanyl, all of us have a hands-on. If you see here, the route of administration is almost exactly similar, IV. But onset of action. Now, in anesthesia, we are judged by how quickly we anesthetize, how safely, and how quickly we awaken the patients at the end. This goes a long way in that. For example, remifentanil starts working in 30 seconds, whereas fentanyl usually takes around 2 to 3 minutes. Morphine, if you give, it probably takes around 8 to 10 minutes for it to work. So this is the one which makes us fasten our anesthesia procedures. Peak effect is probably in 1 minute, and duration of action is 5 to 10 minutes. After 5 to 10 minutes, if you have stopped the infusion, you will not have any effect from this. Now, carefully look at this. I want you to have a look at this particular thing. Now, I call it as a front-end kinetics. So here, if you see here, remifentanil, this is the timeline here, this is the percentage of peak effect. Remifentanil starts working in less than 1 minute for a peak effect site. So the key thing here is the peak effect concentration is achieved fairly quickly. Look at fentanyl, it takes around 4 to 8 minutes. This is the first thing. Front-end kinetics is excellent. That is what we want. The next, is it possible, can reduce the volume a little bit? Okay. Now, one is how quickly it starts to work. Next is how easy it is to achieve a steady state concentration. Now you look at it here. So fentanyl, to achieve a steady state concentration takes such a long time. What about remifentanil? In a matter of minutes, we can have a steady state concentration. Lot of activity is happening in target controlled infusion to achieve this steady state. The 3 compartment models have been modified in such a way that you can achieve steady state very quickly with remifentanil. Now, after you have used it for, let's say, half an hour, 1 hour, how quickly the off effect happens. That is, we can reflect it with context-sensitive half-time. This context-sensitive half-time is essentially, if you have used it as an infusion, how long does it take to reduce by half? If you used it for half an hour, if you stop the infusion, the effect of the drug will not be there in 5 to 7 minutes. If you used it for overnight, for example, let's say 12-hour case, you have done a liver transplant case, at the end of 12 hours, you want to extubate the patient, there it is. At the end of 7 to 8 minutes, the effect is not there. If the patient is not breathing, it is because of some other reason, not because of remifentanil. That is the beauty of this drug. Now, how to use it? It's available as lyophilized form. You need to dilute it with either saline or dextrose water. I personally prefer to dilute it as a 50 microgram per ml concentration. Right? To keep it simple, if you have a 1 milligram, take a 20 ml syringe, dilute it up to 20, and here you have a 20 microgram per ml solution. If you take a 2 milligram, take a 50 ml syringe, but dilute it up to 40 and keep it ready. That is how I would use it. There are people who use it as 20, but that is, I'm telling you how I would use it probably. The moment you load it, label this syringe, label the concentration, label the drug, so that everyone around you is aware what concentration you have. Now, how to use it? Now, remifentanil is a drug which you have to use it as an infusion-only drug, not as a bolus. Now, there are two ways of using it. One is as a TCI pump or through a normal infusion pump. Few of us are lucky to have this TCI infusion pump, and that is probably the best way to use it. Now, when you want to use it as a TCI, what are the parameters you need? Before you go onto the pump, you should note down patient's age, weight, height, and gender. That makes it patient-specific. So we are moving into a domain in which we can call it as a precision anesthesia. So there we are. Age, height, weight, and gender are very important when we go down. The next thing is you have a bit of understanding about whether to target the plasma or the effect site. Now, why is it important? Because target site is very important for us. For example, let's say somebody has an infection in pancreas. Now, we all learned that not one dose is enough. You have to give a dose which increases the plasma concentration. Now, if you closely look at it, infection is not in the plasma. It is not in the blood. It is in the pancreas. You want the concentration in the pancreas to go up. So that is the target there. Whereas in anesthesia, it's all in the brain. The target site concentration, effect site is very important for us. That is where we should target. Now, it's important to be aware what is the dosage or what is the concentration we used. I'm for the first time not talking about dose, talking about concentration in the blood, concentration in the brain. Now, what is the concentration when we start using it as a TCI? You can use from 1 to 15. You can start induction at 1 nanogram per ml, right? If it is propofol, it is microgram per ml. It is here nanogram per ml. If you don't have TCI pumps, you can use it as a microgram per kg per dose. But preferable to use it as a TCI. All you have to do is change the concentration level. The machine does everything. It calculates V1, V2, V3, V4, all the constants, what is happening, what is the how to compensate for elimination, all these things the machines will do. Now, when you start using it, start with a 1 to 2 nanogram per ml. Don't go too high. If you go suddenly high, patient can have chest wall rigidity, they can have other complications. Start with 1 to 2. Pre-oxygenated patient. That is how we would do, isn't it? When the patient comes in, fentanyl you give around 25 or 50, wait for it to work, and then start the induction. The same thing you do here. So when the surgery is happening, most of the times you need concentration levels of 4 to 5 nanogram per ml. Start at 1, pre-oxygenate, along with the propofol, use this at 4 to 5. Now, if you don't have a TCI pump, what should you do? Now, people have worked on it and made it very, very simplified. For example, if you want to use it as a microgram per kg, note down the patient's weight and multiply by 0.12. If you multiply by 0.12, you will get how many ml per hour is equivalent to 0.1 microgram per kg. That makes it very, very easy. So, on an average, if you for a 70 kg, 8.4 ml is what you require, right? If you go to the previous slide, so here, this is the TIVA dosage, microgram per kg per minute. So we are starting at 0.1, that is equivalent to 8.4 ml in a 70 kg individual. In this way, we can still individualize the care what we are giving, make it more precise as what we can. What are the common side effects? If you give it too rapidly, one is the patient can stop breathing. I have seen patients having chest wall rigidity. More because they have given it as a bolus. It is not a bolus drug. It is an infusion-only drug. They can become apneic. At the end of the surgery, after used as an infusion, make sure that there is nothing left in the extension. Either you flush it or aspirate and throw it away. The last thing you want, you shift the patient to the recovery. Somebody comes and flushes, the patient becomes apneic. The fault is not with the drug. It is with the way that we have established the process. Hypotension, it's not a hypotension, it's a big problem. More a bradycardia or a slow heart rate is an issue, which when we start to use, we'll understand. Even if the side effects happens, it is very short acting, very short limiting. Now, other most important thing is I had first-hand experience with remifentanil was way back in 98, 99, when this drug came as an experimental drug when I was doing my PG in AIIMS. We did the case, from whatever literature says, at the end, when we shifted patient to recovery, they were howling in pain, more than any other patient we had ever seen. So we could not understand whether this drug is working or not working. Then we realized just the way the pharmacology is an advantage, it's a disadvantage if you don't know how to use it. As I told, the drug has a very short half-life, very short context-sensitive half-time. At 7 minutes, the drug is no longer there. If you want pain relief, you should have given it 10 minutes before. So whenever you use remifentanil, at least before you start to slow down or stop the infusion, make sure some adequate analgesia is there. It could be in the form of a regional block, which is working, not inserted, regional block which is working, or other analgesic, or local anesthetic, or any other what you want to do. 10 minutes before, you should make sure that the patient has adequate analgesia on board. Now, in short, remifentanil is excellent hemodynamic control. It's an opioid. It's not a hypotensive agent, even though you can use it for giving controlled hypotension. If you use it adequately, it will reduce your overall volatile requirement or propofol requirement and also relaxants. It can be used in any surgery. Any surgery you can use it, even in patients with liver and kidney failures. If you're using it effectively, because you're waking up patients very quickly, you can save plenty of your OT time. I'm sure the management will like you as a person. So a normal pump, how we would do? You need those 4 parameters: age, weight, height, and gender. You feed those. That way it will personalize your medication therapy, right? So all those you feed. At what level we start? We start at 1 nanogram per ml and go up to 4 to 5 and manage. At the right time, give your long-acting or a block. Only then stop it and come down. In between, the surgery is not happening. You don't need to keep it at 4 to 5. You can come down to 1 to 2 because deep analgesia is not required. Let's say you have got a very deep surgery, spine surgery, they are reaming, etc. At that time, you can go up to 5 or 6 also. That is fine. So the machine will tell how much to give. It will automatically give you. Now, take-home messages with this. In your institution, make it a standard protocol, whether you want to use it 20 or 50. Time, huh? What is it? Oh. Okay. Okay. The other important thing what is happening is this group of drugs, what is known as soft drugs. Soft drugs are those which can short-lasting, very quickly metabolized, and patients can wake up quickly. The next important drug is remimezolam. So it's a hugely advantageous drug, which is coming up as a procedure sedation only. It is licensed for procedure sedation both in Europe as well as in America, but for general anesthesia in China, Japan, and South Korea. So this comes as 20 milligram, one of the safest drugs what you can have. What you need to do is basically, it works on GABA A receptors and hyperpolarizes so that the cell becomes asleep and you will have a sedation. Now, it's a novel, short-acting, but ultra-rapid onset and ultra-rapid offset. So the key thing, onset in 60 seconds, I'll take 30 seconds more and finish the. So onset is in 60 seconds, peak action in 1 to 5 minutes, and patient is fully alert, 10.4 minutes, they can be sent home at 45 minutes. It's a wonderful drug which can be used as an infusion as well. TCI is not there, but it will soon come, and I'm sure we will all want to have a hands on it. So normal, the way we want to dilute can use, with plasma light it crystallizes, and wonderful drug for procedural sedation. Give a 5 milligram bolus, after 2 to 3 minutes, can give 1.5 to 2.5. So that's all what we need to do. Minimal respiratory depression, wonderful drug which can be used as a procedural sedation. So what I want to say is briefly this diagram, in which you can see it works very quickly and offset is very quick. Patient can be sent home in 45 minutes. Wonderful for endoscopies and other small procedures. So slightly prolonged recovery if you use it as a GA drug. I've started using this patient-controlled sedation with propofol. Patient-controlled sedation, not analgesia, sedation. When this comes, we will have in reality that patient will have a power when they want to be sedated, when they want to be awake. I can't wait to get my hands on this. Other things I'll share. I think we're running over time. Thank you, sir. So this is a fast, safe, and organ-independent clearance is a beautiful advantage. It's one of the fantastic characteristic drug which can we call it as soft drug. Thank you very much.
Thank you, Subramaniam, for a very nice presentation. It's always difficult to make pharmacology sound nice, and you've done it.
That is so true, sir. We have a unique pharmacology no other specialty has.
Yes.
We are the only specialty where we require the onset to be very quick, and onset to be very off. And we stop, it should stop. And the drugs which are in that group, which we call it a soft drug, are going to be the future. I have not heard of any volatile agent coming into the market. All I will be hearing is about soft etomidate, soft propofol, soft midazolam, which are quick onset, quick offset, and use something else adequately for what is required.
So we'll have questions at the end. Thank you.
Thank you, sir.
Thank you, sir, for that engaging overview of these emerging sedation agents and their clinical utility. Our next speaker is Dr. Balasubramanya H., Professor of Anesthesiology at BMCRC Ballari, to deliver his talk on the anticoagulation dilemma, can discretion enable valor?